Good afternoon, everyone. Thank you so much for joining us today, and I'm sure more of you guys will trickle in. And I know, lunch is probably one of the factor for us today. But anyway, we are going to talk about a very interesting topic, which is, I'm sure every one of us had to encounter at least one time in our life, right? So before we start, I want you all to take 30 seconds and type yourself or text me about one artifact you had to encounter in your entire life, right? Even if it's something simple, like, just 30 seconds. One artifact.
So you can continue.
What do you think? If you've never encountered an artifact, that means we've really not read enough echoes or done enough echoes, right? All right, so our goal today, I'm sure you have one artifact, and our goal today is to cover that artifact which you have on your, on your text, right? And also not just understand what kind of artifacts are these, but understand the mechanism of these artifacts and learn some tips on avoiding them, right? Let's move on quickly to unraveling what are echo illusions, right? Sadly, I don't have any disclosures. I wish I could say I have, all these disclosures. But now let's take a quick look at this video. Are all these balls moving in a circle? Let's see. Can you guess which way this idol is actually moving? If we go back to the first one, actually all these balls are moving in a straight line, right? Can you imagine that? What am I trying to do here? So I'm trying to get to the point that we do make a lot of assumptions about ultrasound, right? And when it comes to ultrasound artifacts, it's not always easy to understand them if you don't know how to interpret ultrasound physics. So which is why today we are going to go through the world of artifact and learn a little bit basics about how to really understand these. Let's quickly move on to this one. Why? Why do we need to talk about this, right? Why are we even bringing this up in our MMI? Remember, always apply ultrasound physics when in doubt and think of basics of an artifact, right? Like, why is it happening? Second, why does it matter to us as physicians or imagers or sonographers? Why? Because it can change management. Guys, imagine we are saying a huge LV thrombus versus an artifact, right? I mean, we are subjecting the patient to anticoagulation, which is definitely a big clinical change for that patient. What else? Always remember, true anatomy is always visible. No matter which view we take a look or where are we looking from, if it's real, it is real, right? And finally, always remember, think in that third dimension, and remember we also have, our multi-modality folks here who are going to help us with adding that third dimension or fourth dimension to everything we see. So very important to think about everything we see on ultrasound from that perspective as well. And remember, again, always go back to your anatomical basics, right? So everything you can see on an ultrasound, you should be able to explain that based on anatomical assessment. All right, let's start with one question. We're going to keep this interactive, guys. Open your phone, go to this website called menti.com, menti.com. All you have to do is type in the number 55868445. Got that, guys? So people who are watching us online, please feel free to text in as well. All right, what do you think our first case is? Is that an artifact? I don't know which one, but possibly an artifact. A pacer wire, or is it an LVAD we are seeing flipping just through the LVOT? Versus is it a dissection? Like I said, audience online, welcome to vote in as well. All right, I think we have a good distribution. So none of you guys think it's an LVAD, right? All right, let's learn about this one, right? I'm going to hide the answer for now. What about this one? So what do you think about this one, guys? Are we going to anticoagulate this patient? Are we going to send blood cultures on this patient? What about this one? Is it pacer in the LV, pacer in the RV? It's not a pacemaker at all, or don't know what it is. Again, viewers online, feel free to chime in. All right, so we are going to learn these cases. See how we have kind of, not a unanimous distribution? That shows how relevant this topic is, right, guys? Like, and we see this on a daily basis, and I think learning the mechanism and also interpretation of how to really delineate these, very, very important for us. All right. What are going to be our objectives? Like we just discussed, we're going to learn a little bit about physics. We're going to learn about how to differentiate the real versus artifact, and also learn a little bit on how to avoid these artifacts. So again, we do have an ambitious agenda, but we are going to make it very brief. We are obviously going to start with our anatomical pitfalls, which I think is always relevant in relationship to what we are learning today. And also remember thinking outside the box. So we are going to talk about a little bit outside the heart as well. And again, the major artifacts which can happen on color, spectral Doppler. You can also see these on 3D actually. So let's start with ultrasound assumptions and points to remember. So what kind of assumptions do we make in an ultrasound system, guys? What do you think? What do we assume about an ultrasound? Any of you? First of all, we think sound always travels in a straight line. Is that true? Actually, no, right? It depends on the pathway. Sound directly travels to the reflector and is back to you. Is that correct? Probably not. What about sound travels in soft tissue at exactly 1540 meter per second? Probably not. So again, another assumption. What about this one? We think that it'll hit the beam's main axis and come directly to us and nothing else happens, right? Again, this is another important assumption. We also think that the imaging plane is thin, but you know what all goes into that imaging plane. And finally, we always think that the strength of the reflection is related to the characteristics of the tissue, which is partially correct, but not completely, right? I know these are a lot of terminologies from ultrasound artifacts, but then we're going to go over them in a simple English, right? Or I should say simple terms, so it's more relatable and understandable. But before we get in, let's start with some of these anatomical pitfalls. Audience, play with me along. I know you all know me. I love to just keep it interactive so we learn from this. All right, so I'll let Andres pick up our first category. All right, let's go with RA. Let's see if you can guess these on the right side, guys. Let me point to that. What do you think that one is? Online viewers can text or type in, interact with us. All right, what's that, guys? What's that in the AV groove? All right, let me. What's that? Okay, how about this one? And I'll show you what's this one. It's an artifact. I guess I heard it's an artifact. Well, these are actually, the first one is actually dilated coronary sinus, guys, right? So there are only two structures in the AV groove. So one is a coronary sinus and the second one is a left circumflex artery, right? So, and if it's something like this, and the other thing which kind of goes with the dilated coronary sinus is that dilated right ventricle as well, right? So the most common causes of dilated coronary sinus is one is elevated RAP or RV failure, which is what we see here. And the second most common one is Persistent left-sided SVC, exactly. And it can be confirmed using a bubble study with a left-sided vein. Very important entity to identify, guys, right? What's this one, the second one? Moderator band, I heard that, right? Very important to identify, especially when the RV is dilated, you can see it more prominently. And what's this last one? How is the overall? Look at the annulus in general. Look at the mitral side. Pretty thickened and calcified, right? So, do you know what is TAC, guys, or TAC? It's nothing but tricuspid annular calcification, right? So pretty much you want to look at the whole heart and see how that annulus is and kind of go back to that, right? All right, let's go back to our original screen, guys. Damien, pick the next one.
Okay, pericardial sinuses.
All right. Very important, guys. I think both from fellows' perspective, sonographers' perspective, and also from audience perspective, I know everybody needs to know what are normal pericardial sinuses, right? What are the two normal sinuses, guys? What do we see? The oblique sinus and the transverse sinus, right? Again, the transverse sinus is mainly located between the aorta and the pulmonary artery, and the oblique sinus is behind the left atrial appendage, often prominently seen when there is fluid around the heart, like in situations like pericardial effusions, right? So in those situations, you can actually see these sinuses more often. What can be confusing in these cases, guys? Look at this one. What's this? Is it a thrombus in the LA appendage? How many of you go with the thrombus in the LA appendage, guys? Which part of the room will agree with me? Okay. What do you think is the real answer? So it is not a thrombus in the LA appendage. What do you think? It's actually fat. It's the epicardial, adipose tissue in the oblique sinus. So when there is pericardial effusion, you just see it more prominently, right? And what kind of visual clues can you get from the rest of the echo, guys? So when you see the echo itself, you're going to see a prominent epicardial fat pad. You're going to see fat in the AV groove. You're going to see more of, lipomatous hypertrophy. So all those signs point that it's just fat in the oblique sinus. So very important one to know anatomically. All right. Who's going next? Clara. Pick your category. Left ventricle, my favorite, or mitral valve, I should say, from all of our favorites. All right. So I want you to guess which one is the odd one here. I'm going to point to what we are showing so it's more clear. So which one is the odd one out? Left upper, left lower, right upper, right lower. Okay, let's see what is this, right? So what's the first one, guys? It's basically apical LV tendon, right? It's a very normal anatomical variant, which is nothing but a, apical LV tendon. What about the second one? It's an LV diverticulum, right? Is that normal or abnormal? That's a completely benign variant as well, right? It's just enfolding of the myocardial crypts. What about this one? If you see it, you see that it's almost directly inserting into the mitral valve, so it's nothing but an apically inserted papillary muscle, which is again a normal variant. What about the last one, guys? That's the abnormal one, right? So you can definitely see a large apical aneurysm. Is this important for us to know? Yes, right? Because we need to know which one is normal and which one is not. But why are we talking about this one? Very relevant, because you want to identify what's the difference between aneurysm, pseudoaneurysm, and a diverticulum. And if you actually look, guys, what's more important here? What's the difference? So the main thing is LV aneurysm usually has a wide neck and is typically located in the apical or the anterior walls, versus LV pseudoaneurysm, on the other hand, has a narrow neck and has a wider base, right? And it's most often seen in posterior or inferior walls. LV diverticulum, on the other hand, is actually a benign structure, right? It's just an outpouching of the LV, and it contains all the three myocardial layers. And how do we distinguish that from the rest of the bad crews, guys? Is basically no enhancement, because it doesn't scar, right? So it's important to know that if you do a CMR on these patients, you're actually going to see that it's a perfectly normal myocardial wall. Very important one to know, guys. All right, let's go back to our pitfalls. All right, who wants to take the next one? I think Fred.
Left atrium.
Left atrium. All right, what about this one, guys? I'll point out again. Well, I gave you the answers, right? So we see this one very often too, right? And actually more than TTE, we see that very often on TEE is nothing but a prominent Coumadin ridge. So the clue is basically that it doesn't have, like it's pretty fixed, right? As opposed to the thrombus, which is very mobile. And also look at the echo consistency of it, right? Like prominent Coumadin ridges are all obviously at the tip of the Coumadin ridge. It doesn't have that characteristic, mobile appearance like a thrombus. What about the second one, guys? How often do we see this? Very often, because we see so many transplants these days. So sometimes, especially older transplant techniques which involve suturing of the LA will definitely have that prominent suture line. How can you identify this, guys? Is it benign or is it really kind of weird? What do you do to identify that? Exactly, that's correct. Check on the older echo, right? So you open up an older echo post-transplant, you see that consistently on all the echoes post-transplant, you know it's basically a prominent suture line. Very important to have that habit of always opening the prior echoes, guys, and knowing what's the baseline. Very helpful clue. All right, I think we are left out with our favorites, which is the valves. Let's see. How can we not talk about the mitral valve, right? This one here is very interesting. What's that? So do we see any prominent kind of nodule-like appearance on the leaflets, guys? Right? Like see those tips of the leaflets? What's that? So are they normal, guys? Yes. So they are called actually Albini nodules, but in simple terminology, it means just they are the prominent insertion points of the chordae. Imagine a very young pliable mitral valve and the chordal insertions are very obvious from the other end. Those are basically the Albini nodules. And look at that, guys. So all those tiny insertion points is what we are seeing on the echo, right? Very important to know that this is a normal variant in younger patients. We went through this. We'll talk about, what about this one, guys? Lambel's excrescence, right, on the aortic valve. Is this normal too, guys? Actually, yes and no as well. Why? Because what are these actually? So these are nothing but filiform fronds we see on the aortic valves, and the pathology here actually confirms the frond-like appearance, right? But what are we worried about when we see these, right? The big worry we always have is how do we distinguish these from fibroelastomas, right? Because fibroelastomas are more pathological, they are more bulkier, they are more finger-like projections. It is very difficult to exactly identify, but that's why sometimes you need TEEs to identify these. And why is it relevant? We thought it was always benign, but actually not really. There are some, data and case reports which have shown embolic strokes and acute coronary syndromes in patients who had these, Lambel's excrescences. So far treatment approaches have been variable. Some people just say don't do anything. Some people suggest dual antiplatelet therapy. And in patients who do have recurrent strokes and all you see is Lambel's, sometimes they also say anticoagulation. So, more work in progress, but important to know that it's one of the anatomical pitfalls to be aware of. And finally, I think we should go with our others, right, guys? Let's do that. Thinking outside the box. So we talked about everything in the heart. What about outside the heart, right? Let's see. So first one, any takers? Is it normal, abnormal? Which group will say normal and which one will say abnormal? Any takers for that? What are we pointing to? Let me show what I'm talking about. There you go, guys. It's nothing but the left brachiocephalic vein. It's a normal anatomical variant, right? Or a normal anatomical left brachiocephalic vein, which is seen in aortic arch shot, right? You see that space above the aortic arch? Very important to know that, guys, right? What about this one? A lot of gunk. We don't even know what we are looking at, right? I'm sure Damien will give us detailed analysis of this. Yes, exactly. It's nothing but a loculated cystic liver with some ascites around it. Important to know again, right? You need to know. I mean, sometimes we get these images, on a simple normal echo. So you do want to mention that or correlate at least with some cross-sectional imaging you have. What about this one, guys? What about the third one? Breast implant artifact. You see how it's going across the whole image, guys, and it's like shadow-like outside the heart? That's a very characteristic breast implant artifact. What about this one? Oh, yeah, there you go. So this was our favorite one, right? Me and Clara actually did that, first image from our lab. But that's nothing but actually a simple hiatal hernia. And it's, what do you do to identify that, guys? It's a very cool thing we can do. So it's basically a retrocardiac shadow with some kind of, like bowel loops, right? Pretty much hiatal hernia. So what can we do? Make the patient drink a soda. So, or a carbonated beverage, and it'll light up this way, right? So a very cute finding from our lab. But I think if you see one, please don't hesitate to have the patient drink a carbonated beverage and continue scanning and capture those cute hiatal hernias. Right, guys? All right. I think we are reaching our end of our, of our anatomical pitfalls. Any questions so far? I think we've covered most of the normal variants. Okay? All right. We're going to have a bonus question, though. Let's see if we can identify this one. So what do you think is the next step when you see this image? So I'm going to start with our sonographers in the room. Okay, I think I'm hearing. Whenever you have an option of doing, multiple things, I think we should go for that one. Right? Agree, guys? All the sonographers? All right. So definitely, right? So you're seeing something. I mean, you probably think maybe it's a mass on the aortic valve. Obviously, you want to be doubly sure before you come up with a diagnosis like that. Imagine a young patient, and now you're subjecting the patient to further testing. Before that, you also want to get or capture these, like whatever you're seeing in multiple images. So perform additional imaging, biplane, multiplane, color Doppler, and add 3D if feasible, right? And let's see, what did we find actually? So this patient, did end up getting a TEE just because it was consistent in multiple views. What do you think is that? Did we see anything on the aortic valve, guys? Nothing, right? So what did we see in the first image then on the transthoracic? What is a slice artifact, right? So it's basically capturing the tip of the cusp in an off-axis view. Very important to know this, guys, because we've had more than few cases in our lab. Exactly, we do want to do multimodality and confirm, hey, is it really an artifact or not? Because it's worth it. But at the same time, you need to be aware of something like this, right, guys? All right. I think now that we covered a bunch, and I'm sure you're already halfway through, you're going to start thinking about this.
The north wind is an elite undercover species. The north wind is an elite undercover species.
I think artifacts is a topic like this.
False. Dedicated data.
I need to move on. All right, let's go into the real meat of the discussion, right, guys? All right, but before we start, let's start about something simple, right? I know it's a boring topic, so we do want to understand this a little bit. So what happens when sound encounters an object, guys? So you have an interface, you're sending sound. What's the most common thing you're going to expect? Obviously reflection, right, guys? And the angle of the incidence is equal to the angle of the reflection, and 90 degrees sometimes. What happens when it hits directly? What's this one, guys? Exactly. So that's basically reflection. What else? If it goes through the interface and goes across, that's basically called transmission, right? So, and again, depends on the propagation speed of the sound in that medium. What happens? What is this one? Exactly, right? So that's basically refraction. So it's passing through, but it's getting refracted at a certain angle. And again, that depends on the propagation speed of the medium. What about this one, guys? That's the backscatter, right? Imagine, so you're sending ultrasound, it hits a specular interface, and you have this backscatter, which is actually what we really use, right? And in clinical ultrasound. And that's the one which we capture for the transducer, and that's the one which is valuable for the information. So important to understand this, because this will determine how do we understand the artifacts. Let's talk a little bit about, why is this important? Let's start with our basics, right? So let's start with our 2D ultrasound artifacts. Simple ones. I know a lot of terminologies, but I do want you to understand the mechanism, like I said. So we're going to talk about 2D or basic ultrasound and some color and spectral Doppler artifacts, contrast artifacts, and a little bit of 3D. Within the 2D, you have all these terms, which is reverberation, comet tail, shadowing, and we have refraction, side lobe, beam width, and range ambiguity. I know you're going to hate these terms, but important to remember from both's perspective. But more than the name, I want you to understand the mechanism and also identify if it's an artifact or not. That's going to be the goal for today, right? Not identify the name, but at least know if it's an artifact or not. Let's start with the important aspect, right? So reverberation or multipath artifacts, right? So these are the most common ones we see. A lot of the times we're going to see these kind of, hey, what do we see? Why do we see 2 aortas? Why do we see 2 atrias? Sometimes you see a pleural effusion, but there is no pleural effusion on the chest x-ray. So what is that? So imagine you're sending a sound wave, right? And then it comes back, hits the reflector, bounces back, and then what happens? You create an image, right? Then imagine the same thing goes one more time. Now what's happening? You create a second image right behind that. Now imagine again it does the same thing. What's happening, guys? Now the third image, right? So which one is the original one, guys? Exactly, the first one, right? So what about the second and third? They are the artifacts, right? Imagine this going on in multiple ways, right? So that's why it's important to identify which one is the real one and what are all the artifacts behind it. And so obviously always the most nearest one is the real image, right? All the others are the reflectors. And they're always at the multiples of the original distance between the reflectors. That's an important clue to identify, right? If you see the distance between this and this is double the distance from this and this. Makes sense, right? And they don't follow anatomical boundaries. They're all over the place. And usually move in parallel with the original reflector, right? If you see the real object, you'll see everything is moving with that one. And for the boards for our fellows, what do you when you see something like that, it's a step ladder artifact, right? So remember that term. They're going to definitely ask this in the boards to identify that it's basically step ladder pattern. How to avoid? That's a more important aspect to know. Change the gain, right? When all these reflectors basically, they shine too much when the gain is too much. Obviously, you want to optimize the gain so you minimize that reflectors. And alter the imaging planes, right? Change the depth so you're avoiding that trigger of that same kind of specular interface. Right, guys? What about this one, guys? So you see how it's like a step ladder, right? But then they're all kind of fused. What about this one? We see this very often. It's the pseudo-pleural effusion, right? Why is it happening, guys? It's just the reflective posterior pericardium which is causing that artifact. What about this one? You see how you see multiple kind of, shadows behind the posterior pericardium? That's nothing but the reverberation artifact. So look at this one. Is this relevant? You can actually see sometimes pseudo-dissection flaps. They're basically from the LA wall. You see this one, guys? Look at the image. The flap is exactly equidistant from the LA wall, and you see another, kind of circle behind it. So the clue is basically looking at the distance. See how it's exactly multiplied from the original reflector, so which is why it's important to know that's an artifact. Let's talk about this one. We see this very often, right? When you see the whole kind of all the reverberations merge into a single line, that's basically a comet tail or a ring down artifact, right? And very often it happens in prosthetic valves. So important to know that this is not something, some echo density or spontaneous echo contrast. It's just basically an artifact. How about this one? All of us have seen this, right, guys? So acoustic shadowing. So imagine a reflector, right? And you see this dense kind of shadow behind what's there, right? Whenever you see something with strong attenuation, basically the transmitted sound doesn't go beyond that structure. And you see this hypoechoic region. You see this one, right, guys? See that how you see a shadow behind that kind of prominent suture line, right? That's an acoustic shadowing. What about acoustic enhancement? Exactly the opposite, right? Imagine a structure which causes brightness and the sound behind it is dispersed into a bright way, right? Do we see this often? Yes, right? Look at that one, guys. See how you see there's a cyst and you see that hyperechoic density behind the cyst. And even here, right? You see the iota, but you see all that hyperechoic kind of shadow behind it. Again, is it important to identify? Yes, because you don't want to falsely call it that there is something echo dense over there, right? All right. I think we have gone through reflections. Let's talk a little bit about this next one, which is interesting. But before that, let's see this one. I'm pretty sure you're all thinking, what does this have to do with our talk, right? I always like, visual images so you can remember, because the next artifact is mirror image artifact, right? So why is it important, guys? Remember, if you're seeing two different structures in the same kind of plane, right? Let's look at this one. Let's look at this example. Look at that one, right? It almost looks like there's a second heart right behind this heart. Right? How about this one? Is it two iotas? Is it two iotas? I guess I've showed you that it's an artifact, right? And also the funny thing is, if you look at the second clip, guys, the color is also reflecting in both, right? So it can happen on 2D and color as well. So it'll look like duplication of iotas. You're seeing two iotas with color flow, but that's nothing but a mirror image artifact. So very important to identify this, right? Let's see if you can guess this one now. What do you think this is? Do you see two iotas, guys? Or aortic valves? All right. Are you confident? Is it just an artifact? Why would I put it in the middle of a talk? I think I should go with the congenital aortic valvular duplication. Right? Actually, you all guessed it right. So important to know this, guys, right? So it's nothing but a ghost image or a refraction artifact of the original aortic valve. And what is more important than identifying that, guys? How to avoid it, right? So always redo that. So the main mechanism obviously is making, because whenever the sound travels, it's hitting that, but then the light is getting, or sound is getting refracted, and it's creating a second image to the original one. So, always remember, whenever you see such things, what do? Change the imaging plane, right, guys? And also change the gain, change the imaging plane, and add biplane if you have to identify it better. All right. I think you're all pros in artifacts now. Let's see if you can identify this one. So case A versus case B. Which one is an artifact? Case B? I'm going to choose Andres to answer this question. A is an artifact, you think? Okay, B is what? Okay. Actually, you know what? The answer is none, guys. Can you imagine? Both of them are not artifacts. So case A, it's actually an unfortunate case of retained guide wire in the descending aorta. So the patient had a guide wire which was lost procedurally. It was not a fellow, I promise. So, and it was kind of found retained in the aorta. Case B is an even more unfortunate scenario where a pacemaker was placed in the LV, secondary to access issues. And I think Andres had presented an amazing variant of that case. But again, important, what do we learn from this, guys? Very important to know relevant clinical history, guys, right? Remember, whatever you're seeing on an echo, you want to put that into clinical perspective. Don't always turf it down. I mean, especially the second case, imagine you just said it's an artifact and you send the patient home, right? So you always want to look at the relevant clinical history. All right, I think let's move on quickly and get rid of these artifacts. The next one is the side lobe artifact. More than understanding the mechanism here, I want you to identify some of the major examples here, right? Remember the case I showed you in the beginning of the talk where you see as if the pacemaker wire is going through the septum, right, into the LV? That's just basically a side lobe artifact. What about this one, guys? You see that kind of flap-like kind of thing in the aorta, right? So that's also a side lobe artifact. So what does that mean? Basically, imagine the same imaging plane, you're adding more images or more echo density or echo reverberation in a line. That's basically a side lobe artifact, right? And how to avoid, basically, again, the same thing. Always, whenever you're seeing which doesn't go with anatomical assessment, go for color Doppler, go for the biplane imaging, and get our sonographers to help us, right? Like, hey, can you take more images of that? Very important, because like we just discussed in the beginning of the talk, it can change clinical management. What about this one, guys? You see this one very typically, we see this very often. So it's a side lobe artifact of a dilated aorta, actually. So whenever you have a dilated aorta and you're doing an apical 5-chamber view or a 4-chamber view, you can actually see that the aorta can cause an additional shadow next to the atrial septum. All right, I think we are all ready to nail the last question, I think, or last few questions. So you see this, I'm pointing out to the stuff in the aortic root, actually. What do? CMR, surgery. I guess you're gonna nail the boards, right? But I know you all identified that it's an artifact, but what is the name of the artifact? Any takers? I guess it doesn't matter, right? We just talked about how it's not the name, but knowing it's an artifact is more important. But I want you to identify it because look at these two events here, guys, right? Look at this one in the bottom, guys. It almost looks as if something is floating inside the heart, right? What about this one? You add color, look at how it is, right? So these are basically what's called as the range ambiguity artifact. It usually feels like floating images, right? Important to identify again because you always can see these in patients who have wires and gadgets inside the heart. All right, so finally, I think it's important, we're going to just put everything into perspective. So obviously, real structures are always there, which have distinct edges, versus artifacts always have, well-demarcated borders, versus real structures always have independent motion and concur with the cardiac cycle, versus artifacts, don't follow these rules. And also, finally, one thing is if it's consistent, right? Imagine you're seeing this in every view, the chances of it being an artifact is less likely versus, not seen in all the views. And you see when you're changing angles and when you're changing the depth, you see this in and out. That kind of points more to an artifact, right? All right, let's quickly move on to color Doppler artifacts. I promise we are almost done. So all the basic 2D ones, we are going to see them on color as well. And a little bit on color gain, I think, which is very important to know. And ghosting and aliasing, guys, right? So let's look at a few examples of color reverberation artifacts. You see this, guys? You see how it's exact duplication here. And this one here, you almost look like there are two vessels simultaneously in the same kind of imaging plane. What's this one? We see that very often. That's called as a ghosting artifact, guys. It's whenever you see a color signal and you have a strong reflector, in this case is like a calcified aortic valve or mitral valve, annular calcium, all that can disperse the colors into bright colors, and it's basically a ghosting artifact. What about this one, guys? If you identify the problem here, I think all our sonographers will be super happy. What's the difference between the first and the second image? Nyquist? I'll say the Nyquist is not a problem. What else? Color gain. Perfect, guys, right? So the first one is actually where the color gain is too low, and the second one is actually the color gain is too high. And how many of you know, all the sonographers, please help our fellows, where is the color gain button on the machine? Exactly. It's the knob of the color Doppler, right? Go back, please, guys. Anybody scanning in the afternoon, try that so you'll understand that, right? So every machine, every time the sonographers do that, thanks to all our sonographers, because they always optimize the color gain before getting the images for us. Important step, but it can really make you kind of feel like, hey, there is kind of, we have falsely interpreted severe MR because of color gain. So it's a very relevant, topic to know. But again, always make sure that the color speckling is, like you optimize the color speckling for the optimal gain first and then scan the patient. What about this one? That's the twinkling artifact. You see that band of alternating colors basically? It's also called the confetti artifact actually. What about this one, guys? Flash artifact. It's nothing but kind of weird colors we see sometimes depending on what is actually causing that reflection. The next one. Do we see all this on color and Doppler, guys? Actually, yes, right? Unfortunately, we see whatever we saw on color on Doppler as well, right? This one, look at this, guys. The first versus second image, it's the exact same one, right? Imagine you have the spectral gain, low versus high, you're going to see that. And the same, this one is the optal one. Imagine you're trying to measure the peak velocity and you have the color gains all over the place. Obviously, it's going to affect the peak velocity measurement. What about this one? Beam width artifact can as well happen on an echo, right? Like on the Doppler as well. Remember, we talked about catching anything happening in that beam of that artifact. What about this one, guys? Did you ever see these Striger stripe ones? Look at that, right? Look at the Doppler there. You almost see multiple.
One thing worth mentioning is that one common phenomenon of that beam artifact that creates issues in the report is TR.
TR.
So there is a tendency, when you get TR, you can, particularly with contrast, you get these very soft echoes that make a velocity of 2.5 become 3.5. And often that leads to a very, very wrong report. So be aware of that one. Sonographers and fellows both. So always think of nodal velocity. You should always measure in that place where you have the most bright signal, because that's the bulk of blood cells that you're reflecting. So from a practical point, that TR is a very common problem in day-to-day.
Yeah. And for audience online who couldn't hear us, basically Dr. Quinones has pointed out to a very important point about identifying the modal velocity on Doppler, especially when a contrast is given. You really want to really look at the modal velocity and measure the exact peak and not over-exaggerate it, right? All right, what about this one, guys? That's the mirror image artifact, right? Or the crosstalk. If you see exactly, it's a reflection of what's going on above the baseline. And always go for the brighter signal, which is the real one. What about this one? We have seen this, again, similar to what Dr. Q is mentioning, right? Blossoming artifact, where you see that everything is kind of blossoming and blooming, so it's kind of identifying falsely high ones. How many of you know what's wall filter, guys? Did you ever even think about wall filter? Actually, no, very important. Because what are wall filters? These are kind of filters which are embedded into our ultrasound platforms to avoid the low velocity filters in the background. Important when you're identifying or analyzing low velocity signals. Like for example, hepatic veins, right? Important to know what is your wall filter setting before you analyze the Doppler, data. So imagine, look at this one, guys. Imagine low filters versus high filters, right? So all the low velocity data is missing in that high wall filter setting. So it's important to know that there is something called a wall filter setting, especially when investigating low velocity flows. And I'll show you the color look at the color on the left versus the right. So you see more kind of flow behind the LA and the RA, right? And that's also because it's catching all that low velocity flow on the color Doppler. What about this topic, guys? I'm sure every one of you who has done a TE in our lab has encountered this problem, right? So I think the discussion is still ongoing on Twitter. We have a big Twitter war going on about, is it a reflection or and a real artifact versus is it like an artifact from the back wall? So you see that double envelope, guys? So when you have a very bright metallic dense, especially like prosthetic valves, you can have double shadowing, right? The sound is going, hitting the valve and coming back, and it's creating that double envelope. The question is, where do you measure, right? So very important to know. So the final verdict is always go for that brighter signal inside, right? So the inner dense signal is the real signal. And there is this nice kind of tutorial you can see from Dr. Han explaining everything. I'm happy to forward you this article, but very important. We've seen this quite often these days, especially because we put so many devices in all our patients lately. You're going to have these bright specular reflections from those devices, which can look like it's a double envelope. All right, we are almost there. The final one, obviously. We're going to skip contrast artifacts because I think Dr. Zogby had covered it in our contrast lecture amazingly well. And the 3D, unfortunately, it can happen in all of these 2D and color artifacts we've seen. We can actually see it on 3D as well. I put some of my favorite ones because these are the ones which we really get annoyed with. If you think about it, you do see acoustic enhancement on 3D as well. This is a blooming artifact from a bright signal from that kind of prosthetic valve. Look at this one. This is a very classic one, actually. We have a case where we said, hey, one of the leaflet is stuck based on the 3D image. But in fact, it was just a dropout artifact, which means you're just not catching the leaflet in the real plane, right? What about this one? We see this very often in AFib patients, right? Because remember, 3D volume sets are always kind of a set of volumes, right? Like you stitch together multiple volume sets, and you can quite often see these stitching artifacts. This one is a railroad artifact. It almost looks like you're taking a ladder inside the heart, but it's in fact just one catheter. So, it's basically a 3D kind of artifact which you see. Important again to identify that is what I was trying to say. All right, last question, guys. What do you think is this weird color flow? So go back to the menti.com, guys. You got that? So is it a VSD? Is it a coronary flow, color flow artifact, or slice thickness artifact? I'm going to show you the image in a little bit. Okay, and I'll show you what exactly is the real one. So it's the same one, right? You see in both the images? The first one looks almost like a VSD, right? But it's actually, what is that? It's pulmonic insufficiency. It's actually a PR jet, which we are catching in a wrong plane. So very important to remember, guys, because we have that elevational plane we forget on an echo, right? So imagine you're doing a PR jet in the, and you're basically flipping it. It can look like as if it's coming from the ventricular septum. Very important artifact to know. What about this one, guys?
Go back to that. So it appears to be in the aortic root. So if it was pathology, it would have to be a break in that wall connecting the aortic root to the RV, which would not be good news, right? What kind of a shunt you would have? Would it be systolic, diastolic? What would it be? All systolic. Yeah. So the fact that you see nothing in systole, the fact that you don't see anything in systole, it's a takeoff. Oops, this is before you call anything. Let's check it. Because if that were a true finding, you have a really hollow systole. Because the pressures in the aorta are always going to be higher than the RV in both systole and diastole. It's a very pretty example of
Yeah. There's a party going on next to us. I don't know if you're able to see it on the menti.com, but the question here is, what is this? Is this even an artifact or not, or what is this going on? Okay, it's a ball and cage prosthesis, but why are we not seeing the ball? Do you think the ball has embolized? Hopefully not. I know this is a tough question. But basically, I'm sure Dr. Q has seen more of these ball cage prosthesis, right? But it's a velocity error artifact. So what happens is, because the ball is moving at a much different pace compared to the rest of the structures, there is misregistration of the, of the signal from the ball and cage. So that's why you just feel like, hey, you don't see nothing, but it's actually because it's coming in a different kind of, like timing compared to the original, original echo. Very important to identify that, guys. So always remember, I know we have talked enough and no more artifacts, I would say. But again, why are we having this talk? Because it's important to know that these things exist. So when you go to clinical assessment of these or interpretation in real life, you really want to know about all these, right, guys? Always remember common sources of error and misinterpretation. True anatomy, always visible, right? Explained based on principles of applied physics. And we learned few points about how to avoid these artifacts, which I think is more relevant. And finally, I think stay tuned. We are going to have artifacts and echo coming out soon. So I think that's going to be an interesting read for sure. We tried to tone down the physics part as much as we could. So something fishy, always consider an artifact. And I think we should let our echo first guys really say, hey, we take the hit, right? So we basically always, analyze and try to come up with the best interpretation, but don't hesitate getting help from our multi-modality folks. So that's another important point I want to say. All right, guys, any questions at all?
Yeah, quick question. I'm assuming that the newer machines we have now that have a lot more digital processing and AI are probably going to help us reduce our artifacts.
Yeah.
So I don't know if there's if what I'm saying has a proof, but I'm suspicious that we'll see a reduction in artifact because they'll be able to process it, make intelligent decisions using the AI and get rid of it.
Absolutely, Dr. Q. So if you think about some of those, older ones, like Dr. Q is mentioning, the question is, hey, do the more recent, machines or the updated softwares have better kind of filtration systems? Absolutely. And they also have autocorrect, anatomical, visualization. Some of these, kind of, 3D ones also, they have those machines where you can actually get rid of all the excessive kind of noise. So I mean, yes, Dr. Q, and I'm hoping that even more, now that we are going to have 4D imaging, we have flow analysis, auto, corrections, it's going to be making it much more easier. And also post-processing of data is also much more easier. You see an image, you want to add something to it, it's easy with these days with the updated ultrasound systems. Adding the biplane or multiplane imaging to an existent image is easy nowadays. So I'm hoping it's less and less of an issue. But still, I'm sure there'll be newer artifacts which will come up with those things as well. All right. Any other questions? Otherwise, thanks again for being here, guys. Appreciate it.